Here to introduce the panelists as a session moderator, Ms. Corey Hughes, Director of Program Integration for Program Executive Office, Defense Healthcare Management Systems, and the Federal Electronic Health Record Modernization Office. Welcome her to the stage.
Welcome. We're glad to have you here today. I want to first introduce who we have with us. I'm Corey Hughes from PEO DHMS, as well as I represent the Federal Electronic Health Record Modernization Office. We have with us Mr. Lance Scott, also with the firm, Dr. Yvette Weber, PEO DHMS, and we're pleased to have with us from Department of Veterans Affairs, Dr. Neil Evans. Due to just a short amount of time, and I know you're all hungry, we're going to go ahead and get started. Dr. Weber, what an awesome opportunity we have in your area to talk about operational medicine. That was really exciting, that presentation we just finished. What does that mean, and can you tell me a little bit how that's working into the overall federal EHR?
Well, thank you, and I hope you all enjoyed the last session, and I hope the videos got you as excited as they get me. I know some of you had questions, so hopefully you can catch me, ask me questions, or any one of the team that were up here. Sorry we didn't have enough time. These products all fit in the Federal Electronic Health Record. As I mentioned at the start of the last session, you know, the objective has always been to make sure we have a single longitudinal record from the moment you enlist through any of your deployments to the battlefield, back again to the VA, partnering with Dr. Neil Evans, and have that one continuous record. So it fits right into the electronic health record. In addition, we're so pleased to have the Coast Guard up here as one of our federal partners and talking about what they look forward to out of our JOMAS portfolio. We will make these tools available to any of our federal partners. We're one federal space. And finally, what I think is really exciting is the amount of experimentation that JOMAS has done with our allied partners. As you've heard many times from the stage, we're the only healthcare system that goes to war, but we don't go to war alone usually. We go to war with our allies. They are really our asymmetric advantage, and it's important that we can share these tools and be interoperable with them. So, and the good news is we're working through that, and with every exercise we get better and better. Thanks.
Thank you, Dr. Weber. Mr. Scott, she talked quite a bit about the federal EHR, and I know that you are representing that office, the firm. Tell us a little bit about where you see that and what's going on in the firm. Sure,
thanks, Corey. So first off, I want to send Mr. Tinson's regrets. I'm up here, and I'm not him. I don't have his flowing lock, so you're not going to be able to confuse me with him.
I like your beard a little better.
Yes, but as you're, you know, Mr. Tinson always says we do better when we do things together. I don't think that that's more true than it is today. The one thing that kind of struck me before I came up on stage is how the definition of together really has morphed over the years. I don't think at the very beginning that there was anybody that, we always knew we would expand and have the partners and the success that we have, but nobody really envisioned that we would have as much success and as many partners at this point in our time. You know, we've got Coast Guard, and NOAA, and AFRH. Dr. Weber is doing some incredible things with that to bring them on board. I think it's important to note that our togetherness really has expanded. And the firm plays a big role in that, bringing together capabilities and tools and functions to make sure that we give our users, make them more efficient at what they do. I think we're at 138 MTFs, 6 VMCs, soon to be a lot more with the VA's future deployments, NOAA, the Coast Guard, and I mentioned about AFRH. So we're very excited about the future and the partnership that we have today.
He said that magical word, efficiency. It's like the word of the year, I'm going to say. So let's talk about that a little bit, Dr. Weber. Efficient and effective when we do things together. So I know you're partnering with the VA. They've got a lot of exciting things going. I'll let you speak to that first and some of the things you're doing, and we'll follow up with Dr. Evans.
Okay, well, in May of this year, the Secretary of Defense and the Secretary of Veterans Affairs signed an MOU really strengthening their commitment to work together in partnership. And part of that MOU was about optimizing healthcare resources across the two departments. And a seamless, integrated, single baseline EHR is certainly a part of that. Certainly enhances all of those activities. And the good news is we've been at it for a while. We were very successful together at FHCC, and we continue with our success across across all manner of activities. So I'll give you a couple of examples. As I mentioned, we have a single software baseline, no small feat, helped and managed and supported by the firm, worked on jointly with the two program offices across the VA and the DoD. And that really shows a commitment. It takes a lot of folks to keep that together, and was just so proud of that. We have a system that's protected by the very best that DoD has to offer. So proud of our cyber posture and the support that J6 gives us in the DHA. We have deployment templates and lessons learned that will help the VA as they roll out the EHR to so many sites. I'm excited for Neil to talk about that with you all. We've done joint work on cloud migration because our data resides in the same data center, and when we migrate to the cloud, we'll migrate together. That's an enormous lift, and we're happy to be doing it together. A lot of efficiency there. We work together on block and cube releases, and we're deconflicting that from all of the deployment activities that the VA is working on. And we're leveraging lessons learned in adjunct capabilities like EILER, seamless exchange, ambient listening. We're learning from one another so that we can work well together. We've also recently adjusted our acquisition strategy, and we'll be competing a full and open EHR contract next year, and we hope to work with the VA to bundle together our economic buying power where that makes sense. So another way that we are collaborating for efficiency and effectiveness. And finally, although the question centered on the DoD and the VA partnership, the federal nature of this EHR makes it extremely affordable to be a partner as a federal partner. And because we've made this investment, it makes it very cost effective for other federal partners to join, small and large agencies. And we're taking advantage of that. And I think that's what this administration wants. And the good news is we're delivering. Thanks.
Sure, I'll just follow on with that. I think I'm here representing the VA, and as Yvette just mentioned, we are moving forward together. And I think that is important. That's kind of the theme of this question is how are we moving forward together? This is a single record, a single software baseline for both DoD and VA, one record that follows through, and we are better together when we are focused on the person at the center. Regina Julian spoke earlier about how healthcare is really about the person, and I think I get excited about how we're deploying technology to really center around the person, independent, frankly, of our departments, right? How we work together. We're very excited in VA to be accelerating our deployment. We announced in March. You heard Lance mention that we're live at 6 of our medical centers, 26 of our remote outpatient, our community-based outpatient clinics, and at over 100 remote sites, call centers, telehealth centers, and the like that support those 6 medical centers and 26 clinics. We announced in March a plan to go live at 13 new medical centers and many associated clinics and remote sites in calendar year 26. All 13 of those deployments are underway and moving along quite well. Those are in the state of Ohio, Indiana, and also Michigan, as well as there's one site that's just over the river in Kentucky from Cincinnati, so we'll call that almost Ohio, as well as Anchorage, Alaska. Those 26 sites are really the beginning of our acceleration. Speaking of doing things together, we spent a lot of time learning from the pattern that DoD set out about doing deployments in waves thinking about how to restructure our vision of deployment, and we're going to be laying out a plan to finish our deployments as early as 2031. And that's over 160 new sites where we need to go live. It's quite a lot to accomplish in the next 6 years. Very excited about the opportunity. And coming back full circle, we don't do that if we're not doing that together with you and DoD, and frankly, together with many of you in the audience, to include our industry partners.
Outstanding. Thank you, Dr. Evans. Anything you want to add, Mr. Scott, before we go to the next question?
So I think the memo that Dr. Weber mentioned earlier that was signed a few months ago, really it made me feel good, because when I read it, I said, so translation, keep doing what you're doing. I mean, we've already laid the groundwork. I think this is probably the most interactive, coordinating job I've ever been in. We cross multiple agencies. We've just done, I think we do really, really well at taking advantage of roadblocks that might come our way and changing them into strengths. Let's not forget or lose sight of the fact that these are all the same people we're talking about here. The patients were once DoD veterans, they might have been in the Coast Guard, but the bottom line is they all share the same record that we're working on. We're going to talk more about OCI and Seamless and other efforts later on, but those are just examples of how great it was to get everyone together. It amazes me how, your time is kind of valuable, Dr. Evans, Dr. Weber, and to get you into forums constantly to look at some of the problems that we face is just amazing to me. And I want to tip my hat to Mr. Tom Hines. The brief that he gave on security in the background was just absolutely amazing to me. It always troubled me to try to get across how secure and how complex our environment really is, but that definitely helped.
So, Mr. Scott, you mentioned a few times together. I've never worked with another organization where we're crosstalk all the time, which seems to be pretty critical. That being said, are there other critical factors or things that you say are absolutely necessary to contribute to the success and continued progress outside of the fact that we clearly have to do it together?
So I think I boiled it down to kind of three big things. We just have to keep adhering to the principles that got us to where we are today. It's definitely served us well, and it's only getting better. We've got in three areas. We've got to improve our interoperability. Not that we haven't done it to date. We've got hundreds of thousands of partners coming together in the joint HIE. We're basically the largest HIE in the entire world, but we can do better. We've got the TEFCA QHIN initiative that's working on making data exchange that much better. I can remember a day back when we were exchanging, rough PDFs and CCDAs, and now we're working on exchanging computable data. It's just phenomenal how far we've come. As Dr. Evans alluded to, we've got deployments on the future, many of them in expanding our user base of FEHR. And lastly, I think a critical factor is cost savings and efficiency. How do we make this better? How do we combine redundant interfaces? Those are all things that we're working on, so we're very excited about that.
Dr. Weber.
Well, I think we have a couple of things we have to do a little bit better on and get right as we continue to optimize our system. I think that one of the first things is our revenue cycle. Many of you in the audience who have been on this journey with us know that we originally deployed the CHR as a clinical documentation system. And then later, when we got to Wave Eglin and Jacksonville, we really introduced a revenue cycle piece and made this part of business. And we've been deploying that system as it stands ever since. And, that was a lot to go from the clinical system and then incorporate the business system, and we're still working on it. There's some gaps, and we're not collecting all of the revenue and workload and not getting all of the credit. And on top of that, we are we need to make sure that these systems are auditable. I think we've all heard about our audit compliance. So we're working really hard, and the good news is that amongst the many, many improvements we continue to make in the system, that you heard a lot over the past couple of days about AI technology and the rapid change of technology, and it's here and it's ready to be used. Over this next year, we hope to employ a lot of this technology that will really help close the gaps in this area. We're excited about deploying ambient dictation, for example, which will really reduce the burden on the providers, make the patient experience better, and also get that note right, which is the first step in the cycle, or a step in the cycle. We're also going to deploy technology that will help us with computer-assisted coding and autonomous coding. These are big priorities for the DHA, big priorities for Admiral Farrell, our functional champion, and we're really excited. Just two other things I think we need to continue to work on. Cloud migration. The migration to OCI is happening in 4 tranches, and it's a lot. There is a lot to it. There's a lot of data moving over, and there are a lot of pieces of software that have to move over. And we just have to continue to pay attention to it. Why? Because it's going to make a big difference in the way that our software runs, in the way that we can be scalable. And it's going to unlock the future of all of this technology that's going to really make a difference for all of our providers and our patients. And then the third thing is, look, this is a massive enterprise. The scale is unprecedented, largest health system in the world, and it's only going to get bigger as Neil deploys to many more VAMCs, and that scale is just going to continue to grow, right? But even though it's a big system, because technology is evolving so rapidly, we have to figure out how to pilot these really good ideas. You heard Ms. Burst talk earlier, and you heard about many of those acquisition initiatives. We have to employ every one of those that were on her slides so that we can make sure that we can get this technology in our systems faster. We have to ID what's out there. We have to pilot it rapidly, and then we have to scale to the enterprise. And together with the partners and our vendors, I know that we can do it, and I'm really excited to make that a focus this year. Thank you.
Sure, I'll add. I think as we think about what is critical to our success moving forward, I mentioned deployments. That's a big deal for us. I think you all in the DoD should celebrate that you are at the back end of, past the back end of deployments and are really thinking about how to optimize the system. I would say that to me is one of our most significant critical factors moving forward, and I think you heard that in Dr. Weber's comments. Those are places where we can work together to continue to take the solution that we've deployed, the federal EHR, and optimize that for our operations to meet the needs of our patients that we're caring for, the staff who are using the system, and frankly, the efficiency and output of our healthcare system to include the quality of care, the efficiency of care, the safety of care, et cetera, right? Like, we can't lose sight of that work. And I think we in VA are at a point where we are now at the same place that DoD was several years ago, that is in an accelerated deployment, and trying to balance deployment, all of the work to get deployments right and do it right, with all of the work to make sure that we're continually optimizing the technologies to support the real aim of the technologies, which is great, high quality, efficient patient care. So a couple things I'd highlight on that, some good news and areas that I think are a critical focus area for us, right? One thing we know is that technology just has to work. We've heard about the importance of making sure that across both of our departments we have the right infrastructure in place, the right cybersecurity structure to make sure that the data is secure, but also the right architecture to make sure that the performance to the very tip of the spear with our end users is great. And if we look back several years, it wasn't where we wanted it to be in VA. That's one of the reasons we paused for a year and a half in our deployment, was to make sure that we were able to really shore up that system performance. To me, that is really sort of baseline work and something that we need to stay focused on. The metrics are so much better. And I think we should all feel encouraged about that. And that is the work of many people here in this room and the work of our teams working together. The cloud migration is an important next step in driving that continued performance enhancement. The second is really thinking about our configuration and how we deliver the record to meet the needs of our end users. We together survey our end users once a year in the federal EHR user survey. And VA, we just decided if anything's worth doing, it's probably worth overdoing. So we now survey the same set of questions twice a year because we've wanted to get a kind of an earlier look at those data points. And in our spring 2025 EHR user experience survey, it was really encouraging results. We're surveying VA users, but now we are surveying in that twice yearly survey some DoD users at James A. Level Federal Healthcare, FHCC, where we together did a joint go live. And what we saw was that people's confidence in using the EHR, for the first time, people end users saying, I am confident using this EHR and I have sort of a belief that this is allowing me to deliver quality care, exceeded 50% at FHCC for those who said they agreed or strongly agreed with that. Our numbers cumulatively were a lot lower than that. So we're seeing a really consistent positive trend in both the yearly surveys, and VA is seeing that in the surveys. And I think part of that is that we together as informatics communities are investing in the improvement of the solution, so that as we've deployed the solution, how do we continue to listen to our end users, make this better, drive that standard single baseline in a way that actually is addressing the needs and the new discoveries of the front lines of care.
Thank you, Dr. Evans. I think we have about 5 minutes left, and so I'm going to give the opportunity for questions. But while people are coming up, I did want to give you guys just one last thing you want to say or that excites you in the future. We'll start. I'll go ahead and go back to you, Dr. Evans.
One thing that excites me in the next year, 1 year from today, we'll be live at another 11 sites. So we'll be at, instead of 6 sites, 17 sites. It's a significant increase. I'm excited about what's to come as we move forward over this year.
Go ahead, Dr. Weber.
If you've only given me one thing, I think I'm really excited about what we can do with the data. We have really matured the MIP to have data from many different places, not just legacy data, but our 130 interfaces. And data is really the oil through this system, not only for interoperability, but for actionable insights and recommendations and decision support. And we really are at a point where this data is being treated as a strategic asset. And I look forward to really improving in this area and really supporting readiness and all sorts of other research and other activities with our data. Thanks.
Every year, I think it couldn't possibly get busier than last year, and every year it does. This year is no exception. There's just to stomp my foot on the OCI transition that Dr. Weber mentioned earlier, that is absolutely huge. We've split it up in tranches. If we do our jobs right, the functional users should see very little change as far as functionality goes, but it sets the groundwork. It lays that foundation that we need to do many more advances that we have on the cusp of the federal EHR. FHCC brought out the need for us to basically allow DoD clinicians and VA clinicians to see the opposite department's patients. We got that requirement at the last minute. We proved it out. Now we're working on an enterprise solution to make that happen. Another thing would be B2B, business to business. The clinicians were absolutely very vocal that using the EHR is not all of healthcare. They have to use SharePoint. They have to use Teams. They have to be able to actually see each other's calendars. We came up with a solution for that with the help of J6. It was just phenomenal. So we're really looking forward to what's happening over the next year.
Exciting times ahead. I'll start over here with you, Mr. Holston.
Thank you so much, Corey. So the federal healthcare system provides care for Department of Defense, VA, but it also provides care for Indian Health Services. Through DHS, it provides occupational health care for Custom Border Patrol agents. And federal health care covers refugee care when they enter the United States as it transitions to civilian care. If you could wave a magic wand or do anything within your power, what would you do to ensure that 3 to 5 years from now, on stage is DHS, HHS, and DOS, all the other federal entities within the firm in the future?
Honestly, I don't think we have to do much because there's a lot of people clamoring at our door now. There's partners have already expanded past what I thought we would ever get, and I think the success of the federal EHR really does help promote that. People want to be a part of it.
Outstanding. Okay. You, ma'am?
Thank you. As the daughter of a Spec Ops Vietnam father, a Vietnam Navy nurse mother, the spouse of a special operator who was medically retired after 24 years of service and put back together by the MHS and the VA, so thank you. Mother of 2 Spec Ops sons and one who is now a veteran. My motivation for my question is not just as an employee, but a consumer of the joint service you provide. Many of us in this room are joint users and fit in that joint thing. I wonder how you guys prioritize the fact that 70% of most of our care is from an injury-based cause, and have we looked at making sure that injury-cause coding travels from the point of injury all the way through MHS, is electronically enabled and motivated through AI, so the desktop provider doesn't have to search for that injury within MHS, so by the time they get to the VA at separation or retirement, the disability process can be even more accelerated. I was part of the team that digitized the electronic health record and took the 300 days plus for disability ratings and got it down within months. I think we can do better. I'm just curious, is this something that keeps you all awake at night? It does me. Thank you.
I can speak to that from the VA perspective, right? I think we have it is our desire to process claims as quickly as possible and as accurately as possible. And, I used to do C&P exams and like way back when in my primary care days. And before we were sharing anywhere near as much data as we're sharing now. I can't think of the last time in 10 years of delivering primary care where I did not have every piece of information that I needed in the primary care clinic to take care of a patient when that data had been collected in the DoD. Now, some of that, to your point, was missing all the way back to the point of injury. And we've already heard in some panel discussions here about how that is being addressed through the work that Jomis is doing. The short answer is when we have a single record and a single record that follows from the day somebody enlists until the day that we're evaluating their disability claim, by definition, that should allow us to be more efficient in doing so. We're going to have the data to make the decision, and we have the opportunity to build then better ways to capture that data and find the insights we need to adjudicate an accurate claim. We're already seeing benefit of what we've accomplished thus far, and I think that only matures as DoD, now DoD has completed deployment, right? So all DoD data is there in the system. We're going to see that continued growth in how VA can receive the data and adjudicate claims more quickly.
Okay, we have time for one last question.
Good morning. My name is Lieutenant Commander Willis. I'm a prosthodontist over in San Diego and their CDIO. Does the current dental solution effectively or efficiently meet identified requirements? Can you discuss next improved steps to improve dental's integration into the enterprise solution, and especially for inbound AI scribe, AI coding, or other big data advancements that currently don't have a whole lot of dental involvement. Thank you.
Thanks for asking the dental question. Does it meet requirements? We get this question a lot. And, you know, part of our philosophy in deploying these systems is to try to use commercial systems. There aren't a lot of great commercial dental EHR solutions out there, but periodically, and even this year, we went and polled what's out there to see if there is anything better than what we have today. And the answer is really what we have is about what the state of the art is today. I will say that we are making, we're doing smart things with PowerChart in MHS Genesis, and you know, you can talk with Dr. Sheets or Dr. Sheets Mrs. or Colonel Dr. Sheets Mr. Who can talk to you about those smart things. We're also, you know, maybe I could just say, we treat dental in many different systems, so there's room for efficiency. You know, if you are deployed and reserve, reserves have one system, there's a deployed system, there's a Genesis system. We grab data from readiness systems and push it here and there. There is a lot of room for improvement and collaboration, and we're doing just that through several MIP projects and Genesis projects to make dental better. But are we going to see something new, a new EHR solution for dental? We just haven't found it. So if you're a vendor out there that has the best, greatest solution and we didn't find it, let us know. But otherwise, we're going to, you know, work to improve things through our Genesis system and make it better. And we're going to improve the efficiency of all of these other systems that we're paying for and that we're pushing data for and through to make sure dental reporting is done in a better and a more efficient manner. And I look forward to working with my DHA colleagues on that as well, and the services. So thanks for your question. It's a difficult area to see a lot of improvements, but we're doing our best.
Okay, and thanks to all of you for hanging out with us through the beginning of lunchtime. Enjoy your afternoon.